See, are you all able to see my screen or not?
Yes.
Great, thank you.
Maureen, I can see your screen.
All right, thank you. I've got to just change, I think, one setting here. All right. Great. Does that still look okay?
Yes, it does.
Great. Thank you, everybody.
So, Maureen, you may want to put it on presenter mode. It looks like you can see the slides on the.
Okay.
On
How's that look?
Now, there you go.
All right. Thank you. Still getting used to all this technology. So again, thank you for joining us today here, everyone. My name's Maureen Carland. I am with Maine Healthcare Association. And today we have a special meeting, and our goal for today is to really provide some clinical updates from Maine CDC, talk about some staff mitigation strategies for respiratory illnesses, review available resources through the Power of Care initiative, and to provide really an opportunity for discussion about respiratory infections, as well as hopefully answer any questions that you all may have. So on our call today, we'll have a few people who will be discussing. We will have experts from Maine CDC, as well as from the Power of Care campaign. Well, the focus of today's call is very much a clinical call. Licensing is also on the call should we have any regulatory clarifications that needed to be made. So with that being said, I'm going to go ahead and introduce to you all Dr. Va, who is the director of Maine CDC. Dr. Va.
Hi, thank you so much, Maureen, for doing this and for facilitating. I appreciate the introduction. Hello, everyone. Good afternoon. It is indeed now afternoon. My name is Dr. Va. I am the director for Maine CDC, and I'm just excited to be able to be here today and be joined here today with our partners that represent Maine Healthcare Association, also the Long-Term Care Ombudsman, the Power of Care campaign, and then we do have offices across the Department of Health and Human Services, including Maine CDC, Office of Aging and Disability, and our licensing team as well. Why do I start here? I just want to recognize that it has been 4 years since the very first case was identified here in Maine, and we've come an incredible long way since over those 4 years. One of our biggest strengths, what I've learned in this new role and talking to our team here on the ground and talking with our partners is that one of the biggest strengths to Maine's response was the relationships that were built over that time and how we work together to serve the populations and folks living across Maine. As partners, we hope to create a space for us, and that's why we're here on this call, is to create this space for us to convene and to discuss issues and updates that are impacting the vulnerable populations that we serve together. Reflecting on those 4 years, to better frame that is that, over the 4 years, one, we are no longer in a public health emergency. We have a deeper understanding. We have the science that has changed and just a deeper understanding of COVID-19 and how it spreads. But more importantly, we also understand at this point that we have effective strategies to keep people safe if used. We know that. We just have to use it. We have to implement it. We also understand that respiratory viruses, including COVID-19, remain a public health threat, and it still poses a significant health threat for high-risk populations. That part hasn't changed. What has changed the calculus, what has changed the math, why we have less folks dying, why we have less folks in hospitals, is the fact that we have these effective strategies. That's what's changed. But what hasn't changed is that it still poses a health threat to the public and also more importantly, to the high-risk populations that we serve. Given where we currently are, the US CDC has recently updated its guidance to the public, to the community. I want to make sure I make that very clear, to the public, to the community, not for healthcare facilities or for long-term care facilities, but to the public. They had updated their guidance to COVID-19 that now lines up with other respiratory viruses, including flu and RSV. This guidance emphasizes those core strategies that I alluded to earlier for the general public. What those are effective immunizations. So staying up to date with those immunizations, hygiene, clean air. Before the pandemic, we didn't have this, to the public, we didn't understand, oh, air movement, ventilation, that helps. Now we know. Having access to good, clean air and ventilation, it does indeed help. In addition to those strategies, testing so that you can be connected to treatment, because we now, again, in a different place, we now have effective treatment. We have the science to show that. And then just the basics. This is why, I talked about respiratory viruses, including COVID-19. One of the basic things we all can do is staying home when we're sick. That sounds very simple, but sometimes, I know that's hard to do. But that's one of the first steps, stay home when you're sick. And then there are added strategies for those at higher risk, because it's important to recognize that as well, especially folks that are high risk for severe illness, including older adults. So today, as Maureen had already outlined, we will provide the latest situational awareness and give updates on the current guidance that I spoke to a bit surrounding respiratory viruses, which also include COVID-19. And I really do hope that the information shared today will strengthen our coordination efforts to truly protect one of the most vulnerable populations in our community during this respiratory season, because we understand influenza will go on until May. And as we're learning with COVID-19, it comes in multiple waves in a year. I also hope that in addition to those updates, I hope that once we provide them, we can have a more informal conversation. I prefer that much more, and give folks time and space to ask questions, raise concerns, react, provide feedback. I really look forward to that conversation the most. Thank you everyone for being here, and thank you, Maureen, for coordinating and taking on the hard job of facilitating this very, very important conversations. And so I'll end there and hand this over to Dr. Benowitz.
Hey everyone, this is Dr. Isaac Benowitz. I'm the Chief Medical Officer and State Epidemiologist here at Maine CDC. And I'm going to start with a situation report to talk a little bit about what's going on with COVID-19 and other viral diseases in our community. And then I'll talk a little bit about what's happening with some of the vaccines and guidance. So nationally, we are really in a different place. We're seeing that the respiratory virus season with COVID-19, influenza, and RSV is decreasing nationally. So we're past the peak. The peak was really late December or early January. But these viruses are still circulating in our communities. They are still causing emergency department visits. They are still causing hospitalizations. They are still causing deaths. If we go on to the next slide, you can see some of the other trends that we're following for emergency department visits and hospitalizations. So on the left, this is a look at emergency department visits across viral respiratory illnesses over the past 2 years. You can see that in late 2022, we saw this really big spike with all across all infection types. And then more recently, we saw this rather large spike in late December, early January. And in between, I just want to highlight, even in between those spikes, disease activity is not going away completely. Particularly with COVID-19, it is circulating year-round. On the right side, you can see the data that we collect for hospitalizations for influenza and COVID-19. So on the top, that's influenza. The red line is the 2023 to 2024 trend line. And right now, we're just at week 10 or week 11. And so you can see here as well, we are continuing to see hospitalizations from influenza. And it's continuing a bit later than what we saw last year. For COVID-19, that's the bottom right, we're continuing to see hospitalizations. This is the number of new hospital admissions, and it's hovering around about 50 to 60 per week. If we go to the next slide, this is a few different ways to look at overall respiratory virus trends in long-term care facilities. And specifically what we're looking at here are outbreaks. So the graph is looking at all influenza outbreaks that are reported to Maine CDC, and it's broken down by type of facility. And what you can see is week after week, the red portion of these bars, that's the nursing home component. These are influenza outbreaks in long-term care facilities. So while we are seeing influenza, while we are seeing influenza outbreaks in other settings, this is something we're seeing much more in nursing homes than anywhere else. And I really just want to show this to make sure that you're all aware that these outbreaks can happen. Really, every facility is susceptible to it. Looking at COVID-19 and RSV, these are not on the graph. I just have some numbers here. So in this season overall, we've seen 164 COVID-19 outbreaks just in nursing homes. And that includes 23 outbreaks reported just since February 1st. And for RSV, we've seen 14 RSV outbreaks in nursing homes during this respiratory virus season. Moving on to the next slide, I just want to share a little bit of information about the vaccines for COVID-19, RSV, and influenza. So you've seen a lot of this information before, but it's really worth reinforcing and repeating. So we have these updated COVID-19 vaccines. They're recommended for everyone really 5 years and older. And the vaccine that we have right now is the one that came out in September. That is a vaccine that targets the XBB lineage of the Omicron variant. Pretty much everything that we're still seeing circulating in the community right now is related to the XBB lineage and to the Omicron variant family overall. The thing that I want to highlight most is the change in guidance that happened in late February. That's when CDC's Advisory Committee on Immunization Practices met and recommended an additional dose of the current COVID-19 vaccine for adults 65 years and older. So now we're still recommending that everyone 5 years and up get at least one dose, but there are additional offerings for people who are 65 and older, as well as people who are immunocompromised. Moving on to the next slide. Just want to talk a little bit about the RSV vaccines. So again, this is really the big game changer this year. This respiratory virus season is the first time that we've had RSV vaccines for all these other groups. So there are 2 RSV vaccines that are available for adults 60 years and older in the US. There's the Arexvy vaccine from GSK and Abrysvo from Pfizer. Both vaccines contain a part of the virus to help the body recognize RSV when an infection occurs. These vaccines are offered under what's called shared clinical decision-making, which means that it's a position where instead of saying that everyone 60 plus should get these, we say that everyone in this age group should talk with their provider to discuss whether these vaccines are right for them. There are some side effects that we're seeing in some of the relatively younger adults. And in this setting, I will simply say that in the nursing home setting, these vaccines are really valuable, particularly in places where we have seen outbreaks and we will continue to see outbreaks. The older you get, the stronger my recommendation gets around the use of one or the other of these vaccines. The best time to get the RSV vaccine is in the late summer or early fall, just before RSV starts to spread in the community. However, anyone in a nursing home who should get this vaccine should not wait until next summer or early fall. This virus is still circulating in our community. Moving on to the next slide, I just want to say a few words about influenza vaccines. So we continue to recommend influenza vaccine for everyone 6 months of age and older. And then specifically for people 65 years and older, there are 3 forms of influenza vaccine. Any of these are recommended over the standard dose unadjuvanted flu vaccine. So there's Fluzone, which is a high-dose flu vaccine, Flublok, which is a recombinant flu vaccine, and Fluad, which is an adjuvanted flu vaccine. All of these are quadrivalent. All of these can be used in someone 65 and older. And then, of course, we do have additional flu vaccines that can be used in any age group. Moving on to isolation and mitigation guidance. So as Dr. Va mentioned, CDC came out with new recommendations for how to manage respiratory viruses in the community. These are not the healthcare specific recommendations. Carrie Rice from our team is going to go into those in a bit more detail in a moment. But for your awareness, I wanted to make sure that you are aware of what the new community guidance is. And really, this reflects being in a new era where we have advancements in combating these viruses. We have these great vaccines and treatments, which are very effective. So on the next slide, big picture, the things that are available for everyone are immunizations, hygiene, taking steps for cleaner air, access to treatment for certain people in certain risk groups, and staying home to prevent the spread of respiratory viruses. And then additional prevention strategies that are available for people, depending on their specific situation, are masking, distancing, and testing, which can be used by both for isolation and quarantine, as well as access to treatment. If we go to the next slide, what I want to highlight is that this guidance is the same across whatever viral illness is causing your symptoms. And the recommendation is that you should isolate until you are fever-free for at least 24 hours without the use of fever-reducing medications, and also until your symptoms are improving. And so 24 hours after your fever is gone and your symptoms are improving, you can stop isolating. However, you're not done. We still recommend additional actions even after you stop isolating. So this is where we talk about things like social distancing, talk about things like masking, staying in areas that have better air circulation if you're able to. So again, this is very similar to what we've recommended for influenza and many other diseases for years. The change is that COVID-19 is now in this category in the community where these are our recommendations. So again, this is community guidance. There is additional healthcare guidance that we'll get into next. And with that, let me pass it on to Carrie Rice from our Healthcare-Associated Infections and Antimicrobial Resistance team to talk a little bit about where we are with the healthcare guidance.
Before
Carrie.
we move on to that, I think Dr. Marino has his hand up. Dr. Marino, do you want to come off mute?
Thanks, Maureen. Hey, Isaac. I had a couple questions, or I guess comments also. One is, as far as the RSV vaccine goes, I understand the original studies did not show a reduction in hospitalization or death as a result of RSV, and the studies were underpowered in adults over the age of 80. Is there new information out there to kind of show that this is something we should be doing? The other thing is insurance companies are not universally covering it. So that's the other aspect of it. So we have not as a group necessarily been just universally recommending RSV vaccines. And there's been more just one-offs in terms of the population. So do you know any more information about that?
Yeah, thanks, Dr. Marino. Appreciate you raising those questions. So the primary endpoints that these studies were able to look at were lung infections, so pneumonia. And for the GSK vaccine, that was for the first season after vaccination, they saw an 83% reduction in lung infections, and then a 56% reduction in the second season. And then for the Pfizer vaccine, I think it was 89% reduction in pneumonias in the first season. And they're still looking at the data for the second season. Yeah. I'm not aware of any final results around hospitalization, but I think these data against lung infection are really powerful. And in the discussions that I've had with clinicians around this data and elsewhere, people are strongly encouraging older patients to get these vaccines.
Okay, I'll have to look at the data again, because when lung infections, and it was the article that was in the New England Journal of Medicine, from what I recall, it was symptomatic disease as opposed to more severe illness. So that's helpful to know. Thank you. And then my other question, which now I'm, of course, because I'm unmuted, I completely forget what I was going to say. Never mind. I will, I'll think about it again.
Thanks.
Thank
Dr.
you.
Vod, did you want to say something?
Yes, I too have a question. No, I don't. But I want to punt this question to our next speaker. I received a really good question. The question was, does CDC consider independent living and residential living in the same category as long-term care? And I will now, I believe our next speaker is Carrie. She'll speak a little bit to this. Thank you.
Yep, and I'll briefly answer, and then obviously I know Bill Monteo is on the call, because this is a question we've received numerous times over the pandemic. So when it comes to sort of how we see it from the state of Maine perspective, for some of you that have been here since the beginning, we have what's called Group A and Group B facilities in long-term care. Our Group A facilities are more nursing homes and what we consider health care by definition. So just to preface, in the information I'm going to be going over, I have pointed out specific healthcare guidance, which means for those people who are CMS certified and or are required regulatory to follow healthcare guidance, this is for you. Now in our Group B settings, and again, I'm going to let Bill Monteo jump in if this is any different from the last time that we talked about this. A Group B facility, some of your res care, your independent living, which don't necessarily provide maybe nursing home level of care, they need to have some type of guidance that they're following. Now, if they choose to follow community guidance, they can follow community guidance, or they can choose to also follow the healthcare guidance. What they really don't want is sort of like a mishing and mashing. So I'm sure if it's something there's missed, Bill at the end of the call can kind of preface and give more of the technicalities on that. But what I am going to be showing today is when I get into kind of the infection prevention control specific, it's specific to the healthcare guidance. I'm not going over the community guidance, which Dr. Benowitz had just done. So I wanted to start a little bit where I'm sort of following where we've talked about how there's been a lot of changes, which is supposed to make it easier for individuals in the public and that guidance, and really want to show and talk about how there's a continuum from what we do in our lives outside of work for healthcare workers and healthcare and how they're connected. And so when we think about how do we bridge that gap, right? A lot of times over the past, we have had outbreaks to COVID, flu, other things because of healthcare workers that potentially came into work ill. So we are impacted by what happens by our frontline workers and our providers in their home lives. And so I just wanted to take a step back and think first about, how do we change health behaviors? We have to understand that knowledge alone is not sufficient to change health behavior. There can be various determinants affecting an individual's health behavior choices, and we have to understand what is driving those health behaviors so we can provide the appropriate support for them to choose those protective health behaviors. And so the things that I have on the slide here are what I would sort of consider things that would lead us towards choosing to do protective health behaviors to prevent us as individuals from contracting a virus and then spreading it to others. And so when we think about what's understanding of driving health behaviors, we have to think about what does the specific individual, so think of your healthcare workers, you really have to know, you have to understand them. You may have cultural differences. You may have difference in education level. You might have differences in how they interpret information. Do you have multi-languages? You have different things. How do they perceive their risk to flu, to COVID, to RSV? How someone perceives their individual risk is what's going to drive them to, do I want to get vaccinated, right? So there's different things for different people, and culturally that might be as well. What's their perception to barriers and facilitators to compliance? So how easy is it for them to get vaccine? How easy is it for them to have access to healthcare for themselves or access to things at their facility that might help them to prevent, spread? So hand hygiene, personal protective equipment. What do they see as the perceived impact of infection prevention and control practices? And so we experienced this a lot during the pandemic, right? The difference between science and people kind of, for lack of a word, believing the science and thinking like, if they don't think that what we're telling them is going to do any good, that goes back to the perceived risk of like, well, I don't think this works anyways. Why would I be compliant in doing it? And so you kind of have to know where your healthcare workers fall in those areas. Then there's the attitudes and behaviors of others. Monkey see, monkey do, right? So we as leaders, we have to, and your leaders, or what I like to call nowadays, we used to use the word champion, but in the culture that we have now, I like to say influencers. So those highly influential individuals at your facilities, leadership, maybe other people that people look to, you know, that nurse that everybody goes to for questions, the provider, maybe it's a CNA. What are they doing? If you can get those influencers to be the people that, you know, lead and they see other people doing it, that can sometimes lead other people to kind of follow the pack and move along as well. And so those are the parts, and that's very complex, and I understand that. And those are the hard things to kind of understand. But you can give someone a whole bunch of information, but if you don't understand how they receive that information, what their barriers to the information are, or really understanding why they choose to do what they're going to do, you're not going to effectively change their health behaviors. So then we think about in our home lives, you know, this is the same kind of things we talk about in healthcare. So respiratory hygiene and cough etiquette, really understanding like that's something you should practice in your home life, you know, when you're out in the public. Source control, really understanding, is there times that I might consider masking in my public life? I know for me, I don't necessarily at this point mask every time I'm out in the public, but there are certain situations where I read the room and I slap a mask on because I've got, you know, Joe Smith over here who's hacking and coughing, and I have to sit here in this meeting and I don't want to go home sick. So it's kind of understanding like when can that impact me and help me in my home life? Vaccination, which Dr. Benowitz talked about, really important. Again, how we help to prevent the onset of severe disease and illness, and may sometimes also help in transmission. Education, thinking about your, you know, do they understand the education so they can practice it at work, but also understand the education they're being provided in their home lives. And leadership support and communication. I have some of these same things on my next slide too, but right here what I want to talk about is we have to have supportive leadership so that staff will feel like they can come forward when they say, I don't feel well, I'm ill. We don't want those people to come to work. And so having supportive leadership for staff to speak up about that, having supportive policies and practices to make sure that they're not coming to work when they're ill so we can kind of figure out what's going on. And that so they feel comfortable to communicate that so that you're protecting your residents and also your other staff as well. Next slide. So you will see that this is very similar to the public slide, but I'm moving now into once we're inside the healthcare facility. And again, some of these things people have talked about in general, but optimizing the use of your administrative and your engineering controls. So things to talk about your air exchanges, your HVAC systems, HEPA filtration. When we think more specific to the specific disease types we might be working with, such as COVID-19, there's very specific guidelines for what we call room turnover of the air exchanges before we should be cleaning and disinfecting the space and putting another individual in there and wearing of the appropriate respiratory protection equipment and your sort of your N95 respirators. Same thing, respiratory and hygiene and cough etiquette. As a facility, thinking about what is going on in my area, what is going on in the state, when might I want to implement a broader use of source control? In the beginning of the pandemic with COVID-19 specifically, we had some very hard guidelines for if it's this, everybody mask. If it's this, you can take it off. Now it's really more about reading the situation in your area, in your community. Perhaps it's what's internally happening to you. Are you in an outbreak situation of something? That might be a time that you want to scale up, and knowing when you can scale down, and having that open conversation with staff that it's not black and white. Like we may do something with the scale up, scale down of masking for this specific outbreak or instance, and it might be different than next time. If they upfront know that things might not be the same every time, they may still not be happy about it, but it can help to ease that kind of like, where's this coming out of left field kind of feeling. Having appropriate personal protective equipment, ensuring that staff are trained and educated. When we think about our respirators, remembering that every staff person has to have medical clearance, has to know what respirator they're wearing and be fit tested to that specific respirator. So we can't just hand any respirator to an individual. We already talked about communication and identification. Along with the communication and identification is having appropriate work restriction policies by disease. So in healthcare, the thing that has not changed is there's very specific guidance for each disease type. And I have a little hierarchical summary in the next few slides based on when we want people to stay out of work, when they can come back. So in the general public, it's been consolidated a little bit more, but in healthcare, it's still specific by disease type. Same thing with your transmission-based precautions, which I'm referring to isolation. Next slide. I'm not going to go over every single piece of information on this slide, and it's not totally comprehensive of everything that is available from the US CDC, but I just wanted to kind of show you that there is a difference. So when we think about this slide right here is specific to the healthcare worker restrictions. So if you have a healthcare worker who is ill with COVID-19, influenza, or RSV, as you can see, when we look at how long do they have to be out of work, when can they return to work, it's different based on the organism that you're dealing with. With COVID-19, there are some nuances that look at the clinical status of the healthcare worker. What type of illness do they have? Are they immunocompromised? Are you using a test-based strategy or a non-test-based strategy? And it's very nicely laid out. We also have on our HAI, I can put the link in the chat, our HAI page for Maine CDC. We have a nice Excel spreadsheet that you can download, plug in dates, and I'll help calculate it out for you based on clinical situation. So we do have some tools to help support that decision making. And then again, when you look at influenza, that one might look more similar when we look at sort of the public guidance, which is 24 hours since the last fever without the use of fever reducing medication, but minimally also, I believe it's like 7 days or so. So it's different than the public guidance. And then other respiratory viruses, based on how they act, is different as well. Next slide. Same thing with when we think about our residents or our patients, and we think about them being placed on what we call transmission-based precautions, or the colloquial term isolation. It is different based on disease type. Similar, you can kind of see when we look at COVID, there's the nuances on what's the clinical situation of the individual, and same thing with influenza and RSV, depending upon the specific disease. And so you just want to make sure that you have some nice policies to go around this so people can rapidly understand this information and kind of know how to implement it, know when to discontinue isolation, and that your infection prevention and control professionals are educated and understand these nuances as well. Next slide. And I believe someone said we will share these. So, and I have all the websites to all these as well. It's hours of reading. I find it fun. Not everybody else does. So the next slide that I just wanted to remind people of, and this is specific to COVID-19, there is a webpage out there from US CDC which talks about staffing, crisis kind of staffing management. So if I get into an outbreak or I get into a situation where I have a lot of staff that are out sick or doing this, what do I do? How do I maintain my continuum of care to provide care to my residents? And so there still is guidance out there, and it's meant to be in a continuum where conventional capacity is where we are supposed to be every day. Then there's conventional and crisis. And so you're supposed to work through the capacities down to crisis being sort of the last resort. And we're supposed to be moving back and forth them depending upon our availability of staff. If you go to the next slide. This is sort of the same thing. I just wanted to lay it out visually in a different way. So if you think of conventional capacity as where we are in every days, and the things that we would do to maintain staffing force and conventional capacity would be things like we talked about: vaccination, things they can do in their home life, source control, monitoring your staffing needs on a daily basis so you know when you're sort of getting into a risk area or not, monitoring locally what's going on, epidemiology of your different diseases. And if that's not meeting your needs, kind of moving down into the conventional capacity, the contingency capacity, looking at the specific guidelines that are offered that you can do for actions within there to get some staff back. If that's not working and you still don't have, then you can move down into the crisis capacity. And I believe, your crisis capacity. The thing about it is, and I've seen this happen a couple times, is you're really not supposed to stay in one capacity. It's supposed to be an ongoing review to see, okay, if I've been at crisis, can I move back to contingency? Or maybe my crisis is over and all my staff are returned and I can go right back to conventional. So kind of having this swinging sort of pendulum of moving forth where I am and having an understanding of my staffing needs, and then implementing the specific guidelines that they offer on the website to enact those things to potentially bring some staff back. And it is complex. However, they do lay it out quite nicely on the US CDC website to kind of help you move through some of these things. And I know I've worked with a bunch of you that have had to do more than once, have had to implement these. I see a hand. I'll just have one more slide and I'll get to the question. Next one. This slide right here is just a link to all of the different resources that drives the information on these slides. In addition to, I think I put on our HAI resource page, which we have a couple of different tools to help you work. So we have an isolation discontinuation calculator. We also have managing exposures and determining what to do with individuals of healthcare workers and of your residents for COVID, and how do I work through that process. So there's a bunch of different helpful tools on there. If you have any questions about them, you can reach out to us and we're happy to help you answer any that we can.
Dr. Marino, did you remember your question?
I do, and I have additional ones now for Carrie. So, and I'm going to preface it by saying I understand that these are federal guidance, and you're just relaying federal guidance. So,
Yes.
I
Don't shoot
do
the messenger is what you're saying.
Exactly. I understand these aren't your decisions. So my first question has to come down to the continued surveillance of asymptomatic disease and screening for COVID-19. Prior to COVID, obviously, we didn't check people for asymptomatic influenza. So is there any indication that that is going to go away in terms of screening for asymptomatic disease? Because I guess I just don't know the evidence that it's still effective in doing so, that it makes a difference.
Yeah, I'll share, Maureen, can I share my screen? Is that?
Sure.
And I have two other comments or questions, and maybe you might, before you show your screen, maybe
sure.
it may be easy to answer some of these things. Before COVID, flu was managed by droplet precautions, so surgical masks, eye protection, gowns, and gloves. Your slide said N95s. Is that a change in the guidance?
So that's a nuance. Yep. So with influenza, if you read down through all the guidance, it's when you're doing an aerosol generating procedure. So when you're doing an aerosol generating procedure with influenza, that is when it's recommended to reduce the number of individuals in the room, wear N95 protectors. So it's about the specific of the situation. Yep. Not all the time.
That makes more sense, and that's very helpful. And actually, because of the risk of aerosolization with it. So, and then the last one is probably more of a statement, and you don't even need to comment on it.
Sure.
The fact that we're 4 years into this, and people have natural immunity, people have vaccine immunity, we have treatments for it. The fact that the general public is now allowed to follow guidelines for stopping after 24 hours of isolation, after fever is resolved and you're getting better, I'm worried that these continued use of some of these guidelines, that the CDC, the federal CDC, did not take into consideration the risk of isolation to these adults. I know we talked about this so many times throughout this, and I think the pendulum has swung. Yeah, okay, so there's people that still get very seriously sick. There are people that still become hospitalized. There are people that pass away from these things. But we have treatments, we have vaccines. Keeping someone in a room for 10 days is just making people wild and just causing a whole host of mood-related problems and risk of falls. And I just want to comment out there that we live in this world of surplus safety, that we're so worried about preventing this, but we're causing other problems. And I know that this is not your decision, but geriatrics is all about weighing the risks and benefits of every single thing we do. And I'm not sure we're still there at the point that it's like a zero COVID policy is the right thing to do.
So yeah, I like you said, I can't answer totally on the behalf of US CDC, but I can give you some sort of thought, some thought points on it.
Carrie, I honestly said you don't even need to comment. It's just more of.
But I have one.
Okay, all right.
So one of the things that to think about is, again, I'm going to go back to prior to the pandemic, is a lot of these guidelines like flu, RSV, they're not new. They were there prior to the pandemic. And so we have always approached healthcare differently than we have approached the general public. And so I was in a call a couple years ago. It was when they had done sort of their first really big de-escalation in the general public. And one of the things to think about it is it is a risk-based approach in the general public. So it is an understanding that, okay, we do these things knowing that and it was a higher percentage, I can't remember specifically, so I won't comment on it. It was a higher percentage than I really thought to what they accept of, here's the percent of individuals that will still have harm or things will still happen. And so but yet because the average general public isn't, a higher risk individual, it was an acceptance of a level of risk in the general public. When we move into healthcare, it is you're not in a hospital. You're not in a hospital. We use hospital first. You're not in a hospital if you're not sick, right? You're not in a hospital bed because you want to be there. There's usually something going on, and there's levels of comorbidities. In a nursing home and some of our res cares, you might not be actively ill, or maybe you're lucky you don't have some of those comorbidities, but you're high risk because of age. And so the approach is a little bit different because of that risk factor when we think about it. I totally agree with you. I think it is more challenging in the nursing home population because it's their home versus, staying in a healthcare situation. That is sort of the rationale as to the why. Now, that being said, what we don't know is, may things change in the future? So I can't speak to any specifics, but I do know now that the HIPAC and CDC and some other of our recommending bodies are in active discussions for looking at all of precautions when we talk about our CDC. It's called Appendix A, isolation guidance and all of that. We don't know if there's going to be any changes in that. There may not be. So I wouldn't kind of sit thinking it's all going to change there. But yes, recognizing it is more challenging. I have seen CDC branch out into different things in different areas based on unique settings. So they for some of you that might be aware, and if you don't, you can send me an email, something called enhanced barrier precautions, which is a different approach for individuals who have emerging multi-drug resistant organisms, or MDROs, because of their home and their healthcare. So again, not a perfect answer, but just sort of throwing some context into that. And let me share my screen real quick. Going back to your screening question, see if this will work. So as it's written, when they changed the guidance about over a year ago, there's no specific guidance that states that you must screen every single individual as prescriptive as it used to be. It kind of talks about I'm going to go up to a top, I'll go up in a minute, but there's a section that talks about you have to have a process to identify persons with signs or symptoms. So that includes your residents or people entering the building. They give some guidelines for that. And then it talks about sort of testing. And so like you said, it says the yield of screening testing for identifying asymptomatic infection is likely lower when performed in some of these different areas. So it's not prescriptively saying you must all the time. What they're really driving facilities to do is look at their overall plans, do a risk assessment. So document out your strengths, your weaknesses, what you can do for guidance to come up with a plan that's going to really work for your unique situation. So you're going to want to take a look at this section, and then the other section, if I move back up here, sorry, I'm scrolling through, guys, is this one where it talks about establish a process to identify individuals. This process might look different at different facilities. And so that's where I say really do a risk assessment, determine what works for you. And then as a part of that, I would highly recommend sort of that pendulum process of, okay, here's maybe your average every day, but if you get into a situation where you're having an outbreak or having more cases, maybe you want to be like a little more go get them to do something a little bit higher. Does that help answer that question?
Yeah, it does. Thank you very much. I like that it seems like things are moving in the direction of, not being so strict about it. Because it's causing these are the collateral damage, the consequences of all these things. And so, good. Thank you.
I think Bill has his hand up, and then maybe we can get to Nicole and then get to more questions.
Yeah,
Bill?
and I apologize. Sometimes I'm like the dark cloud on these calls. Couple of things that I wanted to address. First, there have been some questions about residential care and assisted living facilities and PNMIs. I put in the rules, the link in the chat, the link to the assisted housing rules. These facilities are required under rule to have an infection prevention and control program. And all of that information is outlined in the rules. There's also in the statutes, residential care and assisted housing facilities are part of the definition of long-term care in the Maine statutes. And there is reference in the statutes in some settings. The immunization rules, for example, where residential care facilities are considered healthcare facilities, and I will send those to Maureen. But a lot of your questions about the infection prevention and control requirements for assisted living, residential care, PNMIs are addressed in those rules.
Thank you, Bill. Thank you very much. So let's get to Dr. Benowitz, can we get through to Nicole and then, oh, is that okay? All right. Nicole, you want to go in and spend a couple minutes talking about the power of care?
Thank you, Maureen, and I'll keep it brief. So I'm Nicole Marchese. I'm here with the Maine Long-Term Care Ombudsman Program. I'm just here to provide some brief highlights about the Power of Care campaign and how you may be able to utilize this as a resource within your facility. Next slide, please. So the Maine Long-Term Care Ombudsman Program, in partnership with the Maine Healthcare Association, launched the Power of Care campaign. And this campaign focuses on supporting long-term care facilities to increase vaccination rates among residents. The campaign builds on the prior success of the staff-focused vaccination campaign, which was implemented in October of 2022. And this campaign will reach residents, families, and staff where they live and work. We will also be able to help overcome barriers to vaccination by utilizing this Power of Care campaign and utilizing the ambassador model that we'll learn about in the next slide. The campaign also provides educational material that is utilized through social media to promote the importance of vaccination. And I encourage you to be able to check out the landing page that's put on this slide, the Maine Power of Care. You can also access it through the Maine Long-Term Care Ombudsman Program website as well, if that's easier to access. And it provides more information regarding this campaign. Next slide, please. So this is really a resource for you. We have implemented facility ambassadors, and they are here to help carry out the campaign message. So ambassadors receive monthly stipends. The ambassador provides and shares information on the importance of vaccination to their peers, residents, and family members. And we use this peer-to-peer model. It's been successful in distributing information to staff in the prior focus campaign that was implemented in October of 2022. The facility ambassadors can be beneficial to mobilize your staff to be champions of vaccination. So as Carrie Rice mentioned, those influencers within your facility, those influencers would be great individuals to serve as an ambassador and spread that information among their peers. An ambassador can be an ICP, a CRMA, a CNA, a social worker, or your activities director, with one goal: to spread developed materials for the campaign to their residents and staff and family members. It's also a great leadership opportunity for your staff. I know we do have some current ambassadors sitting on this call today that have recently took on this opportunity within their facilities. A lot of ICPs have found this extremely beneficial because they're already really spreading that wealth of information about the importance of vaccination. So these materials are an additional tool to spread that information within the facilities. I know Ethos Marketing, who develops our messaging, has sent out to all the facilities recently a Spring and St. Patty's Day card to be able to be spread amongst residents. And so if interested in utilizing this as a resource in your facility, feel free to reach out to me, and my contact information is located on this slide. And I'll bring it back to you, Maureen.
Thank you very much, Nicole. So we're going to get into questions, discussions. I know there are some questions in the chat. Please know that if you have a question in the chat and we don't get to it, that we will be posting those and getting the answers for you. So I think we've got Barbie. I think your hand is up. Did you want to? Oh, no, let's go back to Dr.
Yes, it
Benowitz.
is. Oh, okay.
I think Dr. Benowitz wanted to.
Yeah, thanks. So first of all, I got a message from one person in the chat asking about a new COVID, whether there are plans for a new COVID vaccine this coming fall. And yes, that is, you are right. CDC and FDA are planning to have a new COVID vaccine in the fall, likely timed at the same time as the influenza vaccine, and again, updated based on whatever is the major circulating variant at that time. The other thing I wanted to say, and this is just a response or a follow-up to Dr. Marino's comments, I appreciate you raising the concerns around what isolation practices are doing. We hear those, we're aware of it, but you see it every day more than we do. So I appreciate you sharing that. But I think my question is, what's the alternative? What we've moved to in the community is a form of harm reduction that is acceptable in a community setting. We need to maintain a different standard in a healthcare setting. We need to make sure that people are comfortable accessing healthcare and know that it's a safe space. So if you have a suggestion about what we should move to, I'm all ears. I know that, our federal partners are continuing to look at what the other options are. They're continuing to look to make sure that anything we change to is still going to be sufficiently protective. And if you have input to that process, if you have suggestions for how we should describe the content, I'd love to hear it. But it needs to be more specific. So always happy to have that conversation. Thanks.
Can I answer or just respond for a second, Isaac, about what you just said? So this is based purely on anecdotal evidence and observation because there's really nothing to support it. So every time we have an outbreak on a dementia unit, obviously we can't isolate those people because they walk around, they leave their room. Staff are on precautions in the sense that they're all wearing N95 to deny protection of the unit. We just had one recently at one of our facilities, and I think only 5 people got it. And, no one was sick. In fact, I think 4 of the 5 actually had asymptomatic disease because of screening. So I don't know if in real world practice, trying to keep people in their rooms made any difference compared to letting them continue to roam around in the milieu or not. And I guess I come back to natural immunity, vaccine immunity, and also treatments for these things. And I acknowledge this is purely based on anecdotal and observation, but and this is not just one facility, but the incidence of people being hospitalized and getting sick seems to be exceedingly low. And now, granted, this is the circulating variant right now, and things may change, and I get that, and I understand that. But my observations that in situations where we can't isolate anybody because of their cognitive impairment, the outcomes appear to have been the same.
Yeah, I appreciate that. I think, and I thank you for sharing that perspective. I will say there are some additional surveillance data that I did not have a chance to pull into my presentation today, so I do just want to share those briefly. I asked our team to take a look at COVID hospitalizations and COVID deaths since September, so numbers for the current respiratory season. And what they found is that since September, and these numbers are probably about 2 weeks old at this point, there have been 1,167 hospitalizations from COVID, and 21% of them were from nursing home residents. In that same time period, so again, back to September, so about the last 6 months, there have been 210 deaths from COVID-19, and 61% of those are from nursing home residents. So nursing home residents are still making up the bulk of this really concerning number of COVID-19 deaths that we're seeing in the state. And so that's my global perspective. And, I hear you, these other things are a problem. We need to find a path forward. But we're also still in an era where a lot of people are not getting the vaccines that are available to them. A lot of people are not accessing treatment in a timely fashion. People are still getting hospitalized. People are still dying. We need to continue to maintain our vigilance. We need to continue to use these best practices and these tools to reduce those numbers.
Hey, Dr. Benowitz, I'm going to add to that too, because by the way, I'm so glad to have this conversation, right? Dr. Marino, I hear your point, and I'm actually going to provide that level of feedback as well, right? Because, we're always trying to balance that and trying to understand what the experience feels like on the ground. And I know you and your team are seeing that, right? Even though I know you're saying anecdotal, it's still meaningful to us to bring that feedback back to those national discussions. With that being said, Dr. Benowitz is correct. Likely the reason why you're not seeing a change in that guidance right now from the US CDC is because unfortunately that data still shows what he just highlighted in those numbers for vulnerable populations, which unfortunately are nursing home residents and those in healthcare facilities. I wish we weren't there right now and still here, but yet we are. And I think you're right, Dr. Marino, to your point, like this is why we do try to encourage as best as we can vaccines and testing and treatment, even among our own staff, like how do we prevent outbreaks to happen to begin with? And when they do happen, what can we do to protect the staff and get them connected to treatment as much as possible? Because, you're right, isolation does negatively impact individuals in that sense of connectedness and communities, right? And I would hate to have that put us in that position to begin with, but we have all these effective things that are available to us. Somehow we just have to collectively all use them or encourage them among our teams. which has been challenging in itself. One clear thing though, right now where we are is we have those strategies, as I said, we have to use them collectively. But what hasn't really changed is the clinical severity of COVID-19, especially for these vulnerable populations. And you're right, like I don't know what other alternative we have. I would be more than happy to get feedback on that and bring that back. But I will speak the next time I speak to other, state health officers, I'll raise that point in terms of like that level of isolation and the potential impact on the mental well-being of our residents.
So in the spirit of time, if I could just ask, I know Barbie had her hand up. If we could maybe have Barbie ask her question, and then Dr. Va, maybe you could talk a little bit about what potential next steps.
Thank you, Maureen. Mine is actually more a statement. First, thank you, Bill Monteo, for answering a whole lot of people's questions for me. Because I don't just speak for myself, I speak for a whole set of facilities. Is that understanding that what they consider a healthcare worker with the HANA alert that went out and the other is, I think that the problem for our communities is the contradictions, is that these guidances come out for our public community and they keep decreasing and have since the changes of 9/2022, and ours stay the same since 9/2022, based on what these doctors are saying. And I agree with Dr. Marino's verbiage on a dementia unit versus a non, because see it every day. But the statistics don't lie. Our healthcare workers under the HAN alert is anyone who performs a direct medical care, is what it said. So I do just want to appreciate the direct answer from Bill, because it helps when we're getting all the questions from families, from patients as to why we're still doing what we're doing, because to them, what comes back to us is that we're not following the changes and we're isolating their loved ones, and it becomes a very challenging aspect. Do agree that the isolation for our staff and the criteria that's out there may need to be looked at, because the more pressures we have with losing staff who have to wear N95s for 10 days minimum, most likely 3 to 4 weeks for an outbreak to even subside, is further depleting our staffing. And I think there are ways to minimize that outside of wearing N95s as long, as often. If the criteria can be looked at and adjusted at the federal level with a better update than 9/2022, I think that there may be some hope on some people's horizon, because we're losing more people every day. Thank you.
Dr. Va, do you want to, I know we're getting really close to the end. I know Carrie's got her hand up. Carrie, you got something you want to quickly share?
Yeah, I just to kind of add, so one of the things, and I know that we've had a lot of turnover, so not everybody on the call here has necessarily been here throughout the pandemic. So again, I just want to reiterate the conversation and the way we need to have the conversations with staff is this is not new. So we've always had different guidance in the public than we've had in healthcare prior to the pandemic. That doesn't make it easier, but sort of understanding the rationale of why it is. The other thing that makes this challenging is COVID is different than anything we've ever experienced, and it's more and it's ongoing, and it's not necessarily seasonal. And so that makes it challenging. The other part, going back to, because a prime example that's been used multiple times, and this has been the most challenging, is when we talk about behavioral health units, dementia, et cetera, it is a different situation in those. What I have seen many facilities do over time, and I can't speak to how this will be taken regulatory wise if you were to have a survey or whatnot, is when I talked about that risk assessment, is so you have the gold standard. Here's the best way to do it. But if you have a situation that is unique and maybe doesn't quite fit into that gold standard, it's doing a risk assessment to see, okay, I'm not going to be able to isolate this population in their room. It's not going to happen no matter what I do. Okay, then what are the next level things that I can do to mitigate my risk as much as possible? And then also constantly driving yourself to review that risk assessment to see, is there a point I can move back for situation or not? So it's instead of just sort of like, I can't do it, and I'm not saying anybody's saying that, but sort of looking at the unique situation. I've had very many facilities during outbreaks, during situations where they've done these risk assessments to fit something that's going to make the most benefit to the most amount of people, and then trying to drive themselves back to sort of the status quo when they get out of that unique situation. So like the hope of everybody would be that maybe at some point we won't have the number of cases of COVID and be more similar to what it was prior to the pandemic, where maybe you had 1 or 2 influenza residents, you know, a year or something like that, and you could follow all the guidance for just those 2 people. So really, you know, and that takes a lot of critical thinking. It takes a lot of understanding and education, but really sort of driving ourselves to kind of change how we think about it and then risk assess to see how can we have the most benefit for all.
Dr. Va, I know we were hoping to hear from you. I'm seeing a lot of people jump off. I know Rebecca Ivy really wants to ask a question, but if we could have Dr. Va share first so that we can then make sure as many people are hearing her as possible.
Yeah, well, thank you, everybody. And I really appreciate the fruitful observations. This is exactly what we were hoping for, by the way, like just this level of dialogue. If this is meaningful, I don't want to like impose another meeting or whatnot, but like if it's meaningful, I would love it that we do this on a more regular basis because I know things change and evolve. There are other emerging concerns I would love to be able to share with the folks here, and then concerns that you want to raise to us as well. But at least we have like this safe space where we can have that level of dialogue. So that's my request. I can talk to Maureen. You guys can definitely provide feedback to Maureen if that's the direction. If you are willing and you find it meaningful and impactful and you find value in this, if you would like to also continue this level of routine touch-ins. And then I will now pass it to Rebecca Ivy.
Sir, you're under Rebecca Ivy with your
I think
hand
you're
up.
Rebecca Ivy, right?
Yep, you want to unmute? Oh, you've got to unmute.
So I actually am one of the fortunate individuals that has been as a director of nursing through the entire process of COVID-19 and watched the evolution of the regulatory changes to a place where I think Dr. Marino spoke to a little bit as well. I would just ask that the metrics that are being shared by the CDC, that we extrapolate a little bit more of that data, because I've heard that long-term care patients are taking up 24% of mortality rates within the hospital. And I would like to extrapolate, was that an admitting diagnosis? Was that a secondary diagnosis from admission? Because I don't think that data is as accurate as could be. As well, because a lot of residents, when they are going into the hospital for, let's say, a upper respiratory illness or COPD, one of the first things we do is actually test for COVID-19 as a screen. Then they get a diagnosis of COVID-19. But is that the contributing factor that was the result of the hospitalization, or a secondary diagnosis as a result of screening? And what was actually, you know, the data that comes from that? How many of those residents were on hospice that were actually sent to the hospital? Because that still is part of the process. And just to piggyback on Dr. Marino's observations, as being in this entire process for over 3 years, I understand the concept behind doing risk management assessments and evaluations. You actually need people in key positions, which we don't have with turnover on a consistent basis, to put the energy and time in to do the risk analysis, to provide the education, and to reassess. So a lot of these conceptual ideas are not practically applicable. So I would like to just throw that out to the team as well.
Thank you. I know that we've gone over our time. As Dr. Voss said, if these would be helpful to have some regular of these meetings, please send us that feedback. I did put my email in the chat. If you didn't get a chance to ask your question or make your comment, please feel free to shoot me an email, and anything that's in the chat, we will be posting the responses to. So, and this will also be posted on our webpage. Thank you. Dr. Va, anything else?
Yeah, I just wanted to make sure that there's closed loop communication, and to the comment about, you know, how do we make this more practical? Because I agree, like sometimes I hear things and in theory I read them, but the circumstances on the ground might be different. I will take that back internally to our team too, just to see what are other states doing and what can we do to make this lift easier if possible? How do you make it more practical? So I didn't want that last question to go unaddressed. We will review it. Thanks, Maureen. And thank you, everyone.
Thank you, everyone. Thanks for joining today. Have a great day.